Updates in adrenal incidentaloma. An adrenal incidentaloma is a lesion larger than 1 cm in diameter, serendipitously discovered by radiologic examination. The previously reported prevalence was 0.4%. Currently it is reported up to 4%, increasing up to 10% in the elderly. The definition of incidentaloma excludes patients who undergo imaging procedures as part of staging and treatment for cancer. In childhood, adrenal incidentalomas are extremely rare. The etiology of adrenal incidentalomas varies and includes benign and malignant lesions derived from the adrenal cortex, the medulla, or of extra-adrenal origin. The reported frequency varies depending on the context of the study and inclusion size criteria. Some authors conclude, however, that the prevalence of malignant and functional lesions is likely to be overestimated, mainly because of the higher prevalence of malignancy in surgical literature. The distribution of all benign adrenal tumors is generally up to 80%, with that of malignant lesions reaching 5%. Discovery of an adrenal mass raises two questions that determine the degree of evaluation and the need for therapy. Is it malignant, and is it functioning? Malignancy is an uncommon cause of adrenal incidentaloma in patients without a known diagnosis of cancer. Computed tomography (CT) or magnetic resonance imaging (MRI) with 2 to 3 mm cuts may allow prediction of the histologic type of the adrenal tumor with multiple characteristics that we show below. Positron emission tomography with ATF2-deoxy-D-glucose also measures the glucose metabolism that provides function information. Delaying contrast medium washout 10 minutes after administration of contrast. An absolute contrast medium washout of less than 50% is positive. Use of an adrenal biopsy in the diagnostic workup of patients with adrenal masses is not recommended unless there is a history of extra-adrenal malignancy and additional criteria are fulfilled, such as the lesion is hormonally inactive, in particular, a pheochromocytoma has been excluded. The lesion is not being conclusively characterized as benign by imaging. Management would be altered by knowledge of the histology. While most adrenal incidentalomas are non-functional, 10 to 15% secrete an excess amount of hormones. Primary adrenal carcinoma 1.9%, metastasis 0.7%, benign non-functioning 89.7%, subclinical Cushing syndrome 6.4%, pheochromocytoma 3.1%, primary aldosteronism 0.6%. The entities can be distinguished on the basis of the functional presentation of the roots. Subclinical Cushing syndrome is a glucocorticoid secretory autonomy without clinical manifestations of Cushing syndrome. It is the most frequent hormonal abnormality detected in patients with adrenalomas. Pheochromocytoma, catecholamine-secreting tumors that arise from chromaffin cells of the adrenal medulla and the sympathetic ganglia are referred to as pheochromocytomas. The presence of a pheochromocytoma should be suspected in patients with severe hypertension, tachycardia, palpitations, cardiac arrhythmias, anxiety attacks, weight loss, or sweating. Aldosteronomas are rare, less than 1%, causes of adrenal incidentaloma. However, because the majority of patients with primary aldosteronism are not hyperkalemic, all patients with hypertension and an adrenal incidentaloma should be evaluated by measurements of plasma aldosterone concentration and plasma renin activity. Each pathology requires a precise determination for diagnosis. Then we show the current recommendations for the diagnosis. Unilateral adrenal masses. All patients with documented pheochromocytoma and adrenocortical cancer should undergo prompt surgical intervention because untreated pheochromocytoma may result in significant cardiovascular complications. Alpha blockade should be given before patients undergo adrenalectomy. Patients with aldosterone-producing adenomas should be offered surgery to cure aldosterone excess. Adrenal masses with either a suspicious imaging phenotype or a size larger than 4 cm should be considered for resection because a substantial fraction will be adrenocortical carcinomas. Bilateral adrenal masses. The management of bilateral adrenal masses is different from that for unilateral masses. As an example, in cases of subclinical bilateral macronodular adrenal hyperplasia, BMAH, size is not an indication for surgery, as some can be as large as 5 to 10 centimeters with insufficient hormone production to necessitate surgery. Patients with bilateral adrenal masses should be investigated for congenital adrenal hyperplasia. Laparoscopic adrenalectomy compared with open adrenalectomy is associated with less pain, shorter hospitalization time, less blood loss, and faster recovery. An open adrenalectomy is recommended for all larger than 10 cm adrenal masses, including those with benign imaging, as the adrenal mass may be diagnosed as malignant on a definitive histologic review. For incidentalomas with a benign appearance in imaging, repeat imaging after 6 to 12 months. Most experts would consider resecting any tumor that enlarges by more than 1 cm in diameter during the follow-up period. However, most adrenal masses that grow are not malignant. Autonomous function has led to the recommendation of repeating the overnight dexamethasone suppression test, DST, annually for 4 years in cases where initial evaluation is negative. However, the yield and cost-effectiveness of such testing are also unknown. Here you can see the proposed algorithm for diagnosis and treatment of incidental adrenal masses.